So the way that I'd like to break this up is after we do the one-on-one, I'm going to do perinatal, and I want to dig in on that quite a bit. Pertinent to that is I did build and run a clinic dedicated to pregnant and parenting women on a controlled substance, and I took 7 counties worth of referrals for that for a number of years. They didn't have to have addiction. I didn't expect people to make that diagnosis. If they were on any controlled substance, whether purposefully or, per the OB, something showed up in the urine kind of way, we would see them, diagnose them, and then treat them throughout their pregnancy and then after. So we'll dig in on perinatal. We'll also talk about work specific to California. I'm the clinical editor for the toolkit that's coming out for the pregnant and parenting female work that we're doing with Stanford. And we'll talk about what that's going to look like and how that can be helpful for pre-hospital and post. I've written the ACOG presentation that they're going to be pushing out for CDC work on universal screening, assessment, and level of care determination to happen prenatally. So we'll dig into that piece. I expect that to take about 90 minutes. At that point, we'll take a little bit of a stand-up, 10-minute break, and then come back, and we're going to do at that point QA from all of the stuff we talked about before. But then more importantly, what I want to find out is what you want from the next piece of this, because I can hit all the objectives that we had, but I want to make sure that when we leave today that I've actually hit your specific topics that you need to have, the things that you feel like you need to walk away with, and then we'll dig in on those over the period of time, and then at the end, probably for 45 minutes, we'll play Stump the Chump, and then your job is to try to get me in a place where I have to say, I don't know. I don't like to say that, which is why I read incessantly. So we'll dig into those pieces as we go. If you ask questions, because we have a varied group of people here today, I'm going to answer a question starting superficially and then walk all the way into the weeds on it so that we can make sure that we hit everybody's kind of frame of reference and what they want to know. Does that sound okay with everyone? All right, great. So strap in. So this is like the putting the record on 72 rather than slow play for what we talked about yesterday. So we need 3 things to survive, right? We need food, water, and dopamine. And what's interesting about that is we recognize that we need food and water, and most people don't recognize we need dopamine. But dopamine is this chemical that's really important in helping us to recognize motivation, meaning getting out of bed in the morning, meaning connecting with other people. It's a chemical that is required for us to be able to make a connection, a mother-baby bond, a connection with new colleagues that we really feel connected to, a connection with tribal members and a sweat. Those are things that require dopamine to occur. And, if dopamine is not there, then you don't have that. You're separated. So a lack of dopamine looks very flat, very, hey, here's $100. Okay. You're going to jail. Okay. Here's $1 million. Okay. It's your birthday. All right. That's it. It's this very flat affected depression. So lack of dopamine, it looks like that. It's not a cry in the corner depression, which is like this low serotonin depression. It's just very flat affected. So as we talk about dopamine and how important it is for day-to-day living and what the impact of substances are on that, I think it's important for you to recognize what someone looks like without it. And we'll go through and we'll talk about how to recognize that person who doesn't have the motivation, who doesn't have the ability to really connect in the way that we want. So if we really start to look at what does that mean for dopamine, we also have to know where does that dopamine get released from. It's not released from your femur. It's not released from your heart. It's released from this area of the brain called the nucleus accumbens. And it's important to know this, and my patients all know these parts of the brain, because this is the part that we have to work on. Some days we got to do some nucleus accumbens work. Some days we have to do some amygdala work. Some days we're working on the orbital frontal cortex and the lateral habenula. The things we do for behavioral therapeutics are always working on separate or more connected parts of the brain, and they have very specific reasons that we do them. And so understanding the reward system and the parts of that really do help to make it less ethereal for patients who are like, it's just in my head. Well, actually, yeah, because that's where the brain is, and that's where the nucleus accumbens is, and that's where dopamine is, and in that nucleus accumbens, it's been injured because of substances. So let's talk about what that means. it gives them something concrete to think about this. We've studied this enough, and when I say we, that's the collective we, like the larger nerdy group of we around the country and those that do research and in the labs. I wrote a thesis on boron neutron capture therapy and the utilization of it for the treatment of glioblastoma multiforme and the subcellular pharmacokinetics involved with two separate bis-calyxarine compounds. That's pretty nerdy, right? So there are a lot of people who do that for a living, that kind of stuff. So we're going to pull all of that information in and try to consolidate it into a pathway we can understand. So in that nucleus accumbens, on a day-to-day basis, when we wake up, we have about 50 nanograms per deciliter of dopamine. When you woke up this morning, if you woke up on time and you got out of bed and you had your first cup of coffee, or if you're one of those who went for a run, then I'm like, whatever. But at the end, if you got out of bed and you got your coffee and you motivated to get here, that's about 50 nanograms per deciliter, right? 50. That's our baseline. That's kind of what we need to bounce around the day, get it done, motivate to show up to places that we need to go. The bad day, the day you fake vomit on the phone and call in and you can't go to work, if you're really good at it, you actually pour something in the toilet so that you can if you really want to get out of work, that's what you can do. That's about 40 milligrams per deciliter, right? It's a little lower, but it's but it's that day you just don't want to do anything, right? Everybody has that day they don't want to do anything. Everybody does something different. Some people, they eat a bucket of ice cream and watch Netflix all day, and they'll binge watch 15 shows. I take 2 bags of chips and go into the basement and play Xbox all day. That's kind of like what happens, right? Everybody has their own capacity for what they do. But that's the day that we just can't pull it together. We're not motivated to do it. And like I said earlier, if you're not motivated, what are we lacking? Dopamine. They're the same thing, so you cannot have one without the other. Your best day ever, right? The day you simultaneously win the lottery, own an island, and have 2% body fat. Like it just, boom, all done. That's 100 nanograms per deciliter. That's like the best day that we're naturally supposed to have. We're naturally supposed to be there. Food, like your favorite food, is about 94 nanograms per deciliter, so it's pretty motivating, right? Sex, 92, bummer, but it's just where it is. And that's where we're supposed to live, right? We're supposed to live between 40 and 100. Some people live closer to 40, and they're that person who's like, I don't know, everything is not great. That's like they're all day. I used the Eeyore. Does everybody know who Eeyore is? It was brought to my attention. There's a subset of the population that's much younger than me that's like, Eeyore who? Winnie the Pooh, Tigger, Eeyore, a long time ago stuff, right? So it's someone who just everything is bad. And then you have the person who got up and ran this morning, and they're always like, it's Monday, it's awesome, today's going to be great. It's that person. It's kind of annoying, a little frustrating sometimes, but they're there. So we all live somewhere in in that range. The problem happens when we go out of that range. If we go below that range, and we have anhedonic depression, then we have major depressive disorder, or at least one version of major depressive disorder. And that happens because we have this low dopamine, and it's that flat affected person. The person that doesn't get better with an SSRI because it's not a serotonin problem. It's the person who doesn't get better with an SNRI because it's not a serotonin or norepinephrine problem. This is a person whose fundamental chemical for survival of dopamine just isn't there enough. And these are people who may do good with bupropion, like Wellbutrin, right? Because it bumps central dopamine enough. It may make them a little more effectively positive and move that dopamine up a little bit. And it cranks it up maybe by 10. So it can be helpful in that subset of the population. But what about people that go above? How does that occur? Well, that generally only occurs artificially. And it occurs artificially when we use drugs or have certain behaviors that have the ability to stimulate that. The most common one being gambling. But if we talk about things like methamphetamine, if somebody uses methamphetamine, what that does is it takes that that range of 40 to 100, and instead of 100 being your best day, when you take methamphetamine, it goes to 1,100. So we get this 10 times boost in the release of dopamine in the nucleus accumbens. Well, those of us who work in medicine recognize this term called homeostasis, which means that the body wants to be where the body wants to be. It will do whatever it has to do to maintain this homeostasis, this natural, normal environment that it needs to survive. So if I hit it with methamphetamine and it goes to that 1,100 nanograms per deciliter, it will never, ever go back up there. Your brain will never release that much dopamine again in a single hit. That's called chasing the dragon. That's that first time use that no one can ever get again. And they never will be able to. 10 years later, 20 years later, 30 years later, the brain learned its lesson and it never unlearns that lesson. So what if somebody continues to use? Whatever substance or whatever behavior that may be, if they continue to use and it super stimulates dopamine, the brain is like, I don't want to make as much dopamine, so it decreases the production of dopamine. And then if we continue to use, then ultimately that decreases the size of the neuron that produces dopamine. And then in a subset of the population, if they continue to drink or use opioids or use methamphetamine, it actually kills the nerves that are responsible for producing dopamine through a mechanism called apoptosis, where the body and the brain thinks, I don't need this, and so in a programmed way, it destroys those cells. This is a part of the brain that does not regenerate. It is an old part of the brain. It is a very primal part of the brain that is responsible for survival. And it doesn't regenerate those neurons that produce dopamine. And so for those patients who have caused that injury to the brain, what's occurred is a stroke in the happy part of the brain. And so there are some people who don't just get back to, quote, that normal amount of dopamine. So what happens when you have low dopamine is that the body shifts into craving dopamine. If it knows it needs it. So let's say the perfect scenario happens, right? Somebody's been using methamphetamine or marijuana or alcohol, and which, by the way, all of those crank dopamine up pretty high. So you have like methamphetamine at 1,100, you have heroin in the 900s, alcohol in the 800s, marijuana in the 600s, nicotine in the 500s. So all of those things significantly stimulate dopamine way above normal, which is why they are considered addictive substances, because anything that stimulates dopamine way above will cause that reaction of the brain to decrease the natural production of dopamine, then causing the behaviors of addiction. So how does it cause the behaviors of addiction? Well, if we identify that person and we capture them, we've screened for that, then we assess them, we're like, oh my gosh, you have addiction. And then we remove them from the environment and we put them in somewhere. We take away the substance, we detox them, and they're all better, right? Because detox fixes everything. It doesn't, by the way. We'll figure all this out. But at the end of this, you have this person now who I've removed the substance that they've been using, and now their best day ever is like 40 nanograms per deciliter. So that worst day that you fake vomited in the phone and didn't go in is now your best possible day. But your average day, 15 to 20. You wonder why maybe some patients don't necessarily get out of bed, don't show up for an appointment, maybe don't change out of the clothes they wore that they slept in, maybe don't take showers, maybe don't even really eat that much, kind of isolate and hide. They literally cannot produce dopamine enough to motivate to get out of bed, to go to the bathroom, to get out of bed to go get food. And then when we start to get into really complex realities, like out of bed to go take care of their kid, out of bed to show up to their probation officer, out of bed to go to work, all of these things don't occur because of that significant lack of dopamine. The body recognizes that this is not sustainable. And so what it does is it sets in motion a cascade of events and thought processes that we culminate into the term craving. And so craving for a person who has an addiction to either a substance or a behavior is the fundamental drive to obtain that substance or to do that behavior. That drive supersedes basically all logic. And let me explain how much it supersedes it. So we looked at craving for water in a patient who's dehydrated, food in a person who's in starvation, and then those people who had been off of their drug of choice, and it was alcohol and opioids, that had been off of those drugs for 30 days, 60 days, 90 days, 6 months, 1 year, 18 months, and 2 years. So let's talk about that a little bit. So we have this person, and they're inside rehabilitation, and their dopamine is now 10. What if I took a person, and we did this, when I say we, it's again the collective nerdy we. They took a group of patients, and they said, no water for 3 days. Nothing orally, nothing IV. to the point where they had moderate to mild severe dehydration, where when they would stand, their blood pressure would go down, their heart rate would go up, they wouldn't really sweat too much, they had thermoregulation problems. One of these that I was like, how did that IRB actually say okay to this? But, you know, it was medical students, so whatever, just go. And so when they did this, they put them in a functional MRI. Does everybody know what a functional MRI is? So an MRI, you know, magnetic resonance imaging, so it takes a picture of the inside of the brain, and what it looks for is the flow of water across the cells. And the different tissues have a different rate of flow of water across the cells, and it takes a picture of that. And so when it does this, it gives very detailed information about the brain. Now we have functional MRI that details that even further in real time. So when it takes a picture of the brain, it can see what part of the brain is functioning more, because when glucose goes into the brain to make it function, water has to be there. So the more glucose that's coming in, the more water goes in. So it allows us to use this imaging technique to recognize how much function is happening in a part of the brain. So this gives us the ability to take a picture and know what parts of the brain are working and how hard. So when you put somebody in a functional MRI, and they haven't had water for 3 days, and we're sprinkling water on their feet, we're playing waterfall sounds in the background, we have to taste a little water and spit it out. What we find is the area of the brain responsible for craving lights up quite a bit. Lights up to about the relative size of a baseball. Well, we did this for food too. So we took a subset of people, it was 17 in the first study, and then they've subsequently done this in a number of studies, and it's been repeated. But when they did it, they had no food for 5 days. 0 caloric intake. The only calories they got was fluid. That's all they got. So they maintained electrolytes if they needed to, but all they really got was just fluid in the IV, nothing orally, and no food. And they put them in the functional MRI, and they made them talk about their favorite food. They showed them pictures of their favorite food. They actually brought their favorite food into the MRI suite and like wafted the smell into the MRI tube, right? And then they had to taste it and spit it out. And they imaged their brain to look at the craving to take that plate of food, whatever their favorite food was, and looked at what that looked like in the brain. And it's this anterior medial prefrontal cortex that's the part of the brain responsible for that. And when they did that, what they identified was craving that was so profound it was about the relative size of a basketball. Now we know what people will do when they're starving or dehydrated, right? They'll steal from people, they'll break into stores to get food, they'll take it from their neighbors. You know, there's this question of what am I going to do? If you're starving, we will eat other people, right? We've made movies about this, right? You're rock, paper, scissors for who gets the leg. I mean, this is like crazy stuff. But we justify it. We look at it and we're like, that's just survival, man. So when we're looking at this, we know what people will do and we justify it. So let's talk about now what it looked like when we had patients who had a diagnosis of an alcohol use disorder and opioid use disorder for longer than 2 years. So that was how you got into the study. And then you had been withdrawal managed off of your substance, and then they put you in an MRI, functional MRI, and asked you basic questions. And those basic questions were, tell me about the first time that you used, and tell me about the last time that you used. They weren't sprinkling like heroin or meth on their feet and like wafting it in the thing. It was just, it was verbal, and then they would show them pictures of their substance, that they had used primarily in the past. And so when they looked at this, again, they looked at 30 days of no drug in their system, 60 days, 90 days, 6 months, 1 year, 18 months, 2 years. I'm only going to talk about 30 days and 2 years, because the signal actually didn't get any better until about 2 years. And it actually got worse over the first year. So when they looked at this, it wasn't the relative size of a baseball or a basketball. The signal intensity for craving for the drug that they had used was about the relative size of a baseball field. And so what they also found through this is that it almost fully shut down the connection into the frontal lobe, the place where we're supposed to have that higher level thought process, that decision-making matrix that allows us to say, we should not cross the street, in the middle of the night with black clothes on. That doesn't make sense. Or, I should show up to work because I don't want to get fired. I should do these things, for my kid. That place, it basically shut it off. What we also found is that it shut off the ability to take on new memories in the brain, in the emotional center of the brain. So with low dopamine states, you're not able to actually onboard new emotional memory appropriately. So what's another term for emotional memory? Therapy. So if I want to onboard new emotional memory for someone and they have a low dopamine state, all they hear from me is rah, 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 and then they come back for their next session, they don't remember anything for it, they haven't practiced the skills, they haven't done anything, and we're like, why aren't you doing this work? And they're like, well, just help. They don't know what to do. Because we now have a brain that's dopamine depleted. They have no motivation capability, and for us to say, you just need to motivate, is literally yelling at them, you need dopamine. Make more dopamine. We don't really do that for diabetics who need to make more insulin. We give them insulin, right? So this is the reason that I think we should be thinking about why these behaviors are not necessarily a frustration. They're a symptom. So when somebody steals grandma's wallet and goes and buys something, or pawns something from the house, or steals a t-shirt, or commits a B&E, and when those things, when that happens, they're not logically thinking through the positive or negative consequences of going out and having a breaking and entering, right? They're just like, I got to figure out how to not go into withdrawal, and I got to figure out how to get dopamine. They're not thinking dopamine, man, my nucleus accumbens are screwed. They're not thinking that. But what they're thinking about is they are going to die. They are in full-on survival mode, no differently, in fact, 10 times more than if I was starving or dehydrated. And so what I see, especially for patients who show up to the emergency department, is that they're actually using enough of their frontal lobe to realize that coming to the emergency department to what people would call drug seek actually is probably a really well thought out plan. Because we're not going to beat the crap out of you in the emergency department, right? We're not going to steal your stuff. We're not going to sexually assault you. We're not going to do these things. We might say no. So when somebody comes in and they're asking for that dopamine /Dilaudid, then what that's going to mean for them is that behavior is actually them attempting to get dopamine. And in fact, it's probably one of the safer behaviors that we identify, because many of the other behaviors are not that safe. But they don't see it as safe, not safe. It is survival. So as we talk about other things like medications, and we talk about treatment pathways, and we talk about evidence, we need to keep in mind that we understand the neurobiological aspects of addiction better than any other behavioral health disorder. We know more about the locations, we know more about the connections, we know more about the baselines, we know more about the natural history and trajectory. We know all of those things over and above what we know about depression, what we know about anxiety, what we know about schizophrenia, schizoaffective disorder, and that. So for people to generally push back and question, do we really know about addiction? My answer is, yeah, we really do. More than almost anything else that sits in the DSM-5. So as we start to fundamentally put together treatment pathways and options for patients, we have to start thinking about the neuroscience matters, and then the treatments we apply to that should be applied to the neuroscience, which ultimately should abate the behaviors. And if we abate the behaviors, then we abate addiction. Because how do we define addiction? We define it based on behaviors, right? We don't define it based on the presence or absence of a drug. If somebody has a urine drug screen that comes in and it's positive for cocaine and alcohol and marijuana and benzos, and it's Saturday morning and I'm starting my ER shift and I'm looking over this, from that, I cannot tell if that person has addiction. They could have just had a really weird Friday night. Right? So this is, you just can't tell if they have the pathological behaviors that come along with seeking and obtaining and using a drug that puts them at harm or risk, that puts others at harm or risk, that puts your job at risk, that you're unable to control the utilization of the drug. It's behaviors that define addiction. It is not the presence or absence. So if that's the case, then if we give somebody a medication to treat addiction, just by doing that, we're not replacing the addiction, we're stabilizing dopamine and looking at the behaviors. Now, if I gave somebody a medication to help stabilize the addiction and all of those behaviors were still there, then it's not working. If all of those behaviors were there in obtaining the drug I was writing them, then that actually is an addiction to that drug. So we're going to dig into these little subtleties and differences as we talk about it. But I want you to keep in mind that none of this is my opinion. This is data science and math. right? This stuff is sitting in textbooks, it's sitting in articles. Anything that I push out there is not going to be some random one dude's book theory. It's going to be, here are the randomized controlled trials that we've done. Most of what I want to present today as we talk about perinatal and we talk about other aspects of this are things that have been specifically evaluated within the American Indian population, that have looked at rural America as well, because we all know that a study done at Harvard in the center of Boston on people that have lived there with the system that they have doesn't always comport to reality. And so what I want to talk about are the things that we can trust to be true, and I have to leave it a little bit up to you or us together to figure out how we apply that science to your locality, to your culture, to your pathways of treatment. Because what I tell you is not what you have to do. My job is just to give you all the information and the truth that's out there about the science, and how you apply it and where you use it and when you use it is fully up to you. Survival has a very identifiable and predictable set of behaviors that we can see. We know that there are 9 behaviors that uniquely identify the addiction, and so when we learn those 9 behaviors in the DSM-5, we can recognize a patient who has addiction and then even determine whether or not it's severe or mild. Because as we talk about perinatal addiction, or we talk about just MAT later, what we have to realize is that there is a continuum of this disease. I am going to give you one of my theories that I'm in the process of writing up right now, and I'm going to call it out as it is that I think we also should separate addiction into an acute and chronic phase of addiction. Because what percentage of college students temporarily meet for a substance use disorder? I mean, this is an honest question. About 60%. The vast majority of those resolve. So I would be one of those, right? I talk about in college, I tried really hard to be an alcoholic, and I really put effort into this. and luckily, because of genetics and epigenetics and times and friends and support, the switch flipped and I just studied more. I mean, it was pretty straightforward. But I had friends that didn't happen, and so it flipped from the acute phase into a chronic phase. We see this in other diseases like hepatitis C, right? So hepatitis C, there's a subset of the population that if you infect them with hepatitis C, the body just takes care of it, it goes away. And then there are other people that it doesn't take care of it and it flips into a chronic disease. And some people it's so chronic and pervasive that it actually causes acute rapid liver failure. So that kind of mimics what we're dealing with here. And there's also diabetes. So some people have type 2 diabetes that requires insulin and metformin and all of these other medications. And other people just exercise and eat better and work out, and all of a sudden their hemoglobin A1Cs are normal, they don't require medication, and they just live a happy, healthy life. Well, this is a little bit like addiction, right? So we seem to always get into these weird fisticuffs about approach to treatment that don't need to happen. We talk about, well, 12-step abstinence is the only way to go, or MAT is the only way to go. No, it's a continuum. Everybody has their own individual pathway to recovery. Just like everybody has their own individual pathway to getting their blood pressure down, or their diabetes under control, or their migraine headaches under control. It's individual. And so as we think about this, what we have to look at when we institute a program or a pathway, we look at a couple of things. Where's the patient and the person on that continuum? And what are my risks if I don't do A, B, or C? For opioids, as we talk about that, if somebody has an opioid use disorder, if I put them into an abstinence-based pathway, then they have about a 12 to 14% chance of staying, of not meeting criteria for addiction at the end of 1 year. So that means about 80 to 85% of people still meet for an active substance use disorder at the end of 1 year. For alcohol, it has better outcomes for that. For alcohol, it's about 28 to 32% for that. So it's about twice as effective for alcohol use disorder. The other issue we look at is if you start somebody on medication-assisted treatment, it decreases their risk of death in 1 year by 60%. What else do we have in the armamentarium of all of medicine that decreases risk of death by 60%? What about a defibrillator? Now 22%. What about aspirin for a heart attack? It's 23 to 24%. Those are huge, right? And if I don't give an aspirin in a patient with acute coronary syndrome in the emergency department, how many people in here are nurses? One or five of you are calling me the next day and telling me how I'm a bad doctor. Because that's just how it works. We have quality things in place so that we make sure that we have life-saving things that are done, and they are done to a lean Six Sigma, that they are done to the point where we are only missing 1 in a million people that come through there. Because if we don't, people die. But what about something that decreases your risk of death by 60%? And that 60%, remember, is happening in a group of people that are between the ages of 20 and 35. Not 60 and 75. So the number of life years lost to this disease is really complex and frustrating, especially for opioids. So thinking about how we understand medications and how we understand risk and describing pathways to recovery becomes important, especially as we describe at-risk populations like perinatal. So when we start to talk about pregnant and parenting mothers, we don't just talk about mom, right? We've got to talk about baby. We got to think about, we got a twofer there, right? So again, sometimes a threefer, you know. And so when we look at this, I just want everybody to be at least on the same page of what the data shows. The data shows very clearly that if you have addiction, the more severe the addiction, the lower your dopamine status and capability to really logic your way out of this. The lower the dopamine, the more likely you are to continue to use, the more likely you are to overdose. If you have an opioid use disorder, the more likely you are to die. So if we want to stabilize the patient, we can stabilize dopamine. What we do in opioid use disorders, we use two medications primarily to stabilize dopamine, and that would be methadone and buprenorphine. Methadone, people feel weird about this. It's the most effective treatment for opioid use disorder. It's about 70 to 75% effective at 1 year for maintaining a treatment. Buprenorphine or Suboxone comes in a bunch of different forms. We'll dig into the forms it comes in a little later today as we talk about MAT in general, but it's known kind of in the general parlance or in the general term as Suboxone. But as we put a person on that, the average at 1 year is about 60% of patients are still in recovery and in treatment at the end of 1 year. And remember, we're comparing that to kind of standard, pathways of abstinence, which live in the 12 to 14% range. And some of the studies were as low as 8 in the general population. Any questions about where we are right now? And again, this is meant to be interactive. I'm up here for a while, so I would love, yeah.
I was wondering, how long does it take of having a consistent opioid use disorder to actually kill that neuron that creates the dopamine?
That's a great question. So the question was very specifically, how long does it take for an opioid use disorder to cause what's called leukoplakia, which is actually the killing of those cells in the central part of the brain? And the short answer is it depends. It seems to be pretty widely varied amongst genetic makeup, and so some people are more genetically predisposed for that to happen than others. It does seem to be the density of use as well, so the higher the doses of things that you're using do seem to have that effect. The general time frame seems to be about 1.5 years to 2 years of consistent utilization. You can start to knock off neurons.
Okay, so what about like somebody who's used opioids consistently every day for over 10 years?
Yeah, so the short answer for that is maybe or maybe not, because we found that it doesn't happen to everybody. Just like there are some people who, they can smoke their entire life and never get cancer, and they die at 85 drinking a martini and smoking a pack a day. Right? There are just some people that genetically it just doesn't harm them as much. The problem is we don't have a blood test to tell us at this point. So what we have to assume as we're doing the evaluation is we do need to tease patients apart to determine, is this a person who has caused really permanent injury to that part of the brain that's important or not? And that can take some time. So clinically, it usually takes me about 6 months to 7 months of stable treatment to begin to have an inkling of is this a person. But based on the functional MRI data, if you're going to recover, you really don't know until after 2 years. I mean, it can take that long for things to pick back up and get there, but if you've been on stable medication-assisted treatment for over 2 years, and I start to decrease the dose of that medication, and all of that craving comes back, and that anhedonia comes back, that's a high-risk candidate for someone who probably has knocked off some of those neurons to the point where we're going to need to supplement dopamine long-term. And for some, that means lifelong. what that looks like. We're doing studies on that now. But the data suggests that there's a subset, probably 15 to 20% of the population, that for chronic use, they do actually kill some of those neurons. And then there's a middle group that is still going to be dopamine depleted, but enough to function. But they may function better if we add a medication to help raise dopamine more. And then there's some that just bounce back. Some of that has to do with how early in life you used a substance. So if you started at 12 to 13, that's going to look different than if you started at 30. And this is where a lot of the data got really squirrely for 12-step. If I said out loud, if I take a person who has a full-blown alcohol use disorder or opioid use disorder, and I put them in a 30-day program and I monitor them for 5 years, 90% of those patients are completely stable at 5 years and maintain that stability in an ongoing fashion. Is that a true statement? Yeah, it is. Creepy, right? So if I say this, if I take a person and I put them into an abstinence-based program, 30-day inpatient followed by 5 years of monitoring and consistent oversight, only 8% get better. Is that a true statement? Yeah, those are both true. So the question is who am I talking about and who do I apply it to? Because if I take a doctor, pilot, or a lawyer, very specifically, because this is where most of the 12-step research was originally done. Remember, it was kind of built by a doctor and a lawyer, if you think about them. This, although interesting is, those of you who studied the history of 12-step recognize that, you know, the 12-step program as it sits currently is not what originated. It originated actually back in the early 1800s on an Indian reservation, as sobriety circles. And so the Native American population actually was early to this kind of collaborative wellness approach and self-help program. So it's been around a lot longer than the big book would say, but in the end, that program works well for people who are doctors, pilots, and lawyers. But if you are not in that pathway, then you're likely to not do really well with that standard kind of old school approach. So why is that? Is it because I'm a doctor and I'm special? Somehow I have a superpower of not being addicted to stuff? No. What happens though is that in order to become a doctor, pilot, or a lawyer, or PhD, or I'm just trying to consolidate it down, generally speaking, you could not have been impaired through high school because you graduated high school enough to get to college. And then you weren't impaired enough in college to not complete a significant amount of schoolwork and follow through on that stuff. What does it take a lot of to get through college and graduate school and medical school and residency and all that stuff and law school? Motivation, yeah. You gotta be freaking motivated to be like, I'm gonna study for 16 years before I get a paycheck. Right? I started school in 1990 after high school, and I finished my training in 2006. Right? That is no joke. That is some long-term thought. So that's a lot of motivation. And when you're looking at that, there are a couple of thoughts about that. Sure, are there some people who started early because they had so much extra dopamine that maybe they just made it out because they had such a buffer? Sure, there's probably that subset of the population. But most of them didn't start early. Most of them didn't have significant trauma. Most of them had pretty solid support. Everybody has their anecdotal, well, I know this guy. Well, I don't care. I talk about populations. I honestly, I appreciate anecdotal thoughts, or I know an uncle, or I have a friend. That's neat, but we have to build systems. And we can't build systems around individuals. We have to build systems around populations. Recognizing that there are exceptions to every rule, and that's awesome. That's what makes a lot of what we do in science super fun. So when we look at this, recognizing we both have a spectrum of severity of the illness that has to do with the density of injury to the part of the brain that makes dopamine. Then we also have this second layer of when did somebody start and why. Did somebody first utilize and continue to utilize because they were so distraught by the physical violence that they were having at home that that was the only way that they felt comfortable and safe? Or did they start because it was like just kind of fun in college and maybe they got kicked out of a chemistry class and that didn't work out so well that semester, so they decided not to do it the next semester. I mean, so you really have to look at all of these pieces. Addiction is not a monolithic disease. It is varied and difficult and complex, and it has a lot of different parts of the brain. I mean, if I just talked about the very superficial pieces of addiction, we can look at things like the orbital frontal cortex, which assigns value to things. And if you assign value to a substance more than you assign value to your kids, then that's one piece of addiction. Your lateral habinula is the part of the brain that's responsible for your default behavior. Meaning, what do I do if I get really stressed? What's my default? Some people go run, some people do a mindfulness exercise, some people grab a bottle. That's another part of addiction. What about when I have low dopamine and I'm anhedonic and I can't onboard emotional memory to my central bed nuclei of the amygdala? That's another emotional component of addiction. What about if I have unrebridled fear that I won't be able to obtain the substance, or I'm going to have withdrawal? Well, that's the lateral bed nuclei of the amygdala and dysregulation in that area. I mean, I could go on, and it's super fun for me. I could honestly talk about this before. But the big piece is, recognize addiction is not about one thing. It is about a lot of things. And some people will tip their toe into it and meet those behavioral criteria, but it won't cause damage. They'll have some extra dopamine, they'll have some support around them, and they'll bounce out. And they will not go from the acute to the chronic phase of addiction. The chronic phase of addiction is what we see most often. Because most of the people here are the ones who are like, I just put down the drink on Wednesday, and I'm done. Okay. I know hundreds of thousands of people who can't. And so we have to build the system for those who can, not those that can. And as we look at this and we talk about perinatal, we have to assume for risk of death to mom and baby that they can't. They might be able to, but let's not rush it. Let's make sure that we get a healthy baby and an alive mommy to the very end. And if we do that, then what we're going to do is set up a chance that instead of having mommy have a baby that goes to CPS and then foster care, and then mommy have to go into the court system, that we send home a family. And that is a really cool thing. Does anybody here treat perinatal or involved in that group of patients? Yeah, I mean, I'll tell you, if I had a chance to open a clinic, if I went back to clinical practice, it would be dedicated to this population. It is the funnest patient ever. They're very motivated, they're heartfelt. They are wrecked though. They've been so beaten up. The depth of trauma in this population is unfathomable. The amount of sexual assaults, the amount of physical assaults, the amount of neglect, the amount of just the power dynamic of the male to female crushing down on them on a regular basis is just, I mean, it's really, really hard to fathom unless you sat there and listened to hundreds of stories. And still, I'm a white male doctor. I'm never going to fully get that, even hearing it. But I'll tell you, there are nights I still stay up and think about these stories. They're rough. And that's a population, though, that really wants to be well. They want to be in recovery. They want to be a good mom. They want to raise their children. They want to do these things. And our job is to set up an environment where that's the default. Not where that may happen and we have the story of the one who made it through, but that we set up a system so that the vast majority of moms who have a substance use disorder are identified super early, are put into very trauma-informed, appropriate evidence-based treatment, not shamed for doing it, and they get support from Child Protective Services, they get support from parole if they have that on their docket to deal with, that the family court knows what to do, that their family is educated about the approach, and that at delivery they don't get shamed by somebody who doesn't know anything about addiction, who happens to be in the delivery room, or a random person studying to be, a pediatrician who says something offhanded, or somebody in the NICU who says, there's so many layers of places where we can punch somebody in the face emotionally. Right? And we do that. We really do that as it walks through. And many times we punch them in every one of those phases. And so let's talk about specifically perinatal. What percentage of OBGYNs in the country screen routinely for addiction? Other than tobacco, which is JACO required. Less than 10%. Well, that's a bummer, right? Because this is a pretty high cause of premature miscarriage, premature delivery, and mortality, during pregnancy. So, what percentage of OBGYNs or family practice physicians who treat them have an X waiver to provide buprenorphine for moms? It's under 1%, pretty far under 1%. How many systems are actually set up to even understand how to do that well? right? To really be like, wow, we found her. All right, so we've done a screening test, and whether that was a urine toxicology test, a validated verbal screening tool. So what's a validated verbal screening tool? Like the NIDA-4, you know, that's the basics. So when you screen for something, all you're identifying is the risk that they possibly have it. It's not a diagnosis. We're just screening for the possibility that it may be in their system. So, if you know, that they may be doing something. So if we do that, then that means if I ask that in the last 30 days if you smoke tobacco, yes or no? If yes, that's a positive screen for tobacco. In the last 30 days, if you had more than 4 drinks at one time or more than 10 drinks in a week, yes or no? Right? In the last 30 days, have you used a substance for something or a prescription for something other than prescribed? If that's yes, then you move on as a positive screen. And then the other, have you used any illicit substances? Yeah, in the last 30 days, have you used an illicit substance, yes or no? So that's one version of it. There's the 4 Ps, there's the 4 Ps plus. There's other screening tools that are specific to pregnant patients. But the problem is they're generally not asked. And then if they're asked, we feel like we somehow have to fully refer that person for treatment, even though it was only a screening tool, it wasn't an assessment. So we don't even know if they have the disease of addiction. Again, maybe somebody went out and partied pretty significantly, they had a great Saturday, they went and saw their football game that they were gonna, hang out at a tailgate or something, and they didn't know they were preggo. So they go out and they had 5 or 6 that day, and they come back, so they have to answer yes to the alcohol question. All it means is we need to screen them and move past that to assessment. So the assessment is the tool that we use to identify if there's a presence of a disease, and if they have the disease, how severe is it? And then once we identify if they have the disease, then we do the severity scan, and then we move to a level of care determination. So where should we be sending moms who are pregnant and have addiction? Where should we be sending them? Yeah? Specialized Drug Treatment Center for Pregnant and Perinatal. That'd be amazing. We can just drop that in. Like the Army has the surgical centers that they helicopter in and just drop in the middle. It's like, boom, operating room. We just need that for addiction. We're like, boom, level 1, level 2.1, level 2.5, level 3.1, boom. And the answer to this is, well, it depends on what the level of care determination looks like. Because treatment is not treatment. Remember, it's a really multifaceted disease, so there's a whole lot of stuff that goes on. We look at things like the 6 dimensions of care, and we look at the ASAM criteria, and we look at, we got to talk about withdrawal and intoxication. Like, do we have to withdrawal manage this person, and that may require a higher level of care and some different people with different knowledge. Do they have medical problems with their pregger? So, that's something we got to keep an eye on, and not everybody feels comfortable about that. So we need to look at that. But if they don't have hypertension or diabetes or those things, then that's fine. Do they have psychiatric issues? Do they have co-occurring mental illness? Like, do they have bipolar disorder? And not meaning do they have a bad temper, right? That gets thrown around all the time. Do they have literal bipolar 1 or bipolar 2? Do they have schizoaffective disorder, schizophrenia, this kind of stuff? But then we move into more esoteric things like what is their risk of relapse? What is their readiness for change? What does their recovery environment look like? All of those 6 things, the 6 dimensions, once those are analyzed appropriately, that can help us to determine where we need to send them for care. Right? So not everybody just needs an outpatient prescription for buprenorphine. Some might actually need an opioid treatment program with methadone because you get seen every single day. That's the beauty of that medication, because it's not necessarily the medication that makes the difference. Remember when I talked about how it was the most effective treatment? I don't think we can necessarily attribute that to the medication. I think we attribute it to the intervention, because the intervention is somebody sees you every day. And for some patients with these very chaotic lives, that's the first time that they've ever had a consistent, day-to-day anything. And they need that. It helps structure. It's like an indirect dialectical behavioral therapeutic approach. It just creates that pathway of care. So the it depends is important, because yes, they may need that. Yes, they may need residential. Yes, they may need all of these other pieces, but we have to figure that out when we see them, and we should be doing a better job early with it. So American College of Gynecology has a CDC grant here in California. They're going to be pushing out a bunch of trainings that talk all about screening, assessment, and level of care determination. Those all start here in the next 2 months. I wrote that in conjunction with them, and so we're going to be able to start pushing that out, talking about all the tools you can use. And my answer is, I don't care what tool you use, just pick one. and then make sure that you pick one, if you can, that everybody else in your county uses. That way you can all communicate. That makes things a lot easier. All right, so that's kind of the screening, assessment, level of care piece. Anybody disagree with that? Be like, nah, I think we're cool. It's working.